Welcome to Dr. Balga's podcast for the Curious Doc. Today is April 4, 2026. This is on a JACC State-of-the-Art review on cardiogenic shock survivorship, published just 3 days ago on 1st April 2026, just accepted. It's a multidisciplinary approach across the continuum of care. What does survivorship in cardiogenic shock mean? It extends beyond discharge to longitudinal cardiac, multi-organ, cognitive, psychological, frailty, and recurrent heart failure outcomes. Why is survivorship a priority now? In-hospital survival approaches 60 to 70%, yet one-year mortality exceeds 40 to 60%. Nearly 1 in 5 are rehospitalized within 30 days. What are the three phases of the proposed continuum? First, acute rescue and stabilization. Second, in-hospital optimization. And third, trajectory assessment and post-discharge shock care. What is recovery? Sustained reverse remodeling with near-normal biventricular function, functional reserve, and improved quality of life. What is remission? Resolution of shock with partial, not complete, reversal of heart failure. Ongoing surveillance remains necessary. What is native heart survival? Survival without durable LVAD or transplant, even if ventricular dysfunction or functional limitations persist. Are recovery, remission, and native heart survival mutually exclusive? No. Patients may overlap or move between them as physiology evolves. Why is early recognition critical? Patients can worsen rapidly, and early deterioration is associated with worse short-term outcomes. Why is non-acute myocardial infarction cardiogenic shock often under-recognized? Decompensated heart failure, valvular emergencies, and myocarditis may lack hypotension or classic hemodynamic collapse. How is severity staged? The SKY framework classifies risk dynamically from stage A, at risk, to stage E, extremis. How dynamic is shock severity? Many patients change SKY stage within 24 hours, especially stage B patients. What limits traditional risk scores? They estimate early mortality but do not reliably distinguish reversible from irreversible injury. What is the survivorship role of temporary mechanical circulatory support? Temporary mechanical circulatory support restores perfusion and buys time to clarify etiology, reversibility, rehab potential, and destination therapy. When should temporary MCS escalation be considered? When serial assessment shows inadequate perfusion or progression despite therapy, ideally before irreversible organ injury occurs. What guides temporary MCS de-escalation? Milestone-based evidence of resolved shock and sustainable cardiac performance should guide weaning. What physiologic targets support temporary MCS de-escalation? The review highlights cardiac index above 2.2 liters per minute per square meter, improved filling pressures, lactate clearance, and adequate RV reserve. Why do access and cannulation choices matter? Axillary or subclavian access better supports ambulation, whereas femoral access more often limits mobility and conditioning. Why address delirium, weakness, and social stresses early? They are early elements of post-intensive care syndrome and can worsen disability, adherence, and late outcomes, which in-hospital targets can modify trajectory, revascularization, structural or electrophysiologic intervention, initiation of GDMT, mobility, nutrition, and psychosocial support. What revascularization strategy is favored first in acute MI cardiogenic shock with multivessel disease? Initial culprit-only PCI is favored over immediate multivessel PCI. When are structural interventions considered? Selected patients with severe mitral regurgitation, aortic stenosis, or other valve disease may benefit when anatomy and physiology are favorable. When are electrophysiologic interventions considered? Refractory ventricular tachycardia, unstable atrial arrhythmias, conduction delay, or high arrhythmic burden may justify ablation, rhythm control, CRT, or ICD planning. How should heart failure GDMT generally begin after stabilization? Once perfusion improves, the reviewers favor starting lower blood pressure effect agents first and then adding RAS blockade cautiously. When are beta blockers usually introduced? Generally after inotropes are discontinued, with limited exceptions such as selected milrinone supported patients. What should be completed before discharge? Decongestion, GDMT planning, reassessment of reversible drivers, destination therapy alignment, and a structured transition plan. What post-discharge pathways follow native heart survival? Recovery, remission with persistent vulnerability, a recurrent decompensation requiring advanced therapy or palliative evaluation. Why is post-shock risk stratification iterative? Late congestion, low output, cardiac arrhythmias, or organ dysfunction may emerge from apparent stabilization. Which imaging tests are central after discharge? Serial echo is foundational. Cardiac MRI adds tissue characterization, fibrosis assessment, and mechanistic insight. Which biomarkers are emphasized? Serial NT-proBNP with high sensitivity troponin are central. Emerging biomarkers may refine risk further. When is CPET or invasive hemodynamic reassessment useful? In persistent symptoms or borderline status, they may clarify functional capacity and advance heart failure decision making. When is genetic testing informative? It is especially useful in non-ischemic cardiomyopathy, where TTN, LMNA, RBM20, DSP, and FLNC variants may shape risk. What residual structural or rhythm issues need reassessment? Valve disease, ischemia, recurrent arrhythmias, and device candidacy should be re-evaluated after stabilization. Why is post-intensive care syndrome screened after cardiogenic shock? This review recommends cognitive, anxiety, depression, PTSD, frailty, nutrition, and social support assessment. Why use a multidisciplinary post-shock clinic? It consolidates follow-up, reduces therapeutic inertia, and supports structured risk reassessment and survivorship care. What core disciplines should post-shock programs coordinate? Advanced heart failure, interventional structural cardiology, electrophysiology, rehab, mental health, pharmacy, and social work are central. What are the four main functions of post-shock clinic? Accelerate GDMT, coordinate cardiovascular reassessment, embed PICS care, that is post-intensive care syndrome care, and channel patients into clinical trials. Who should be referred? The review suggests automatic referral for all cardiogenic shock survivors not discharged to durable MCS, transplant, or hospice. What follow-up cadence is proposed? Early at 7 to 14 days, intermediate at 4 to 6 weeks, and consolidation at 3 to 6 months. How can remote monitoring help? Pulmonary artery pressure sensors, rhythm monitors, and wearables may detect deterioration early and guide titration. What outcomes should programs track? Rehospitalization, GDMT dose intensity, congestion, cardiac arrhythmia burden, functional recovery, PROs, and LVAD or transplant escalation. What outcomes should future trials measure? Survival alone is insufficient. Quality of life, patient report outcomes, cognition, and functional recovery should be included. How can registries and real-world data advance care? Standard longitudinal data sets can define phenotypes, compare care models, and support registry embedded trials. What is meant by shockomics and artificial intelligence here? Multiomics plus machine learning may identify subtypes and deliver dynamic individualized risk prediction. Why are multi-center networks important? They improve harmonization, generalizability, care transitions, and access to trials across referral systems. How should success in cardiogenic shock be redefined? Beyond short-term stabilization, success should include durable recovery, fewer rehospitalizations, preserved function, and quality of life. This is a fantastic review. Go ahead and read it in JACC. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.